Hello, everyone. Thank you for having me on here. My name is Sindhoora Koneru. I'm an M2 from the University of Incarnate School of Osteopathic Medicine. My case that I'm presenting today is a rare case of anti-NMDA receptor encephalitis presenting with subacute neuropsychiatric symptoms in an older patient. So to introduce, we have a subacute change in mental status with behavioral disturbances and seizures in an adult raises a broad differential, including infectious, metabolic, toxic, psychiatric, and autoimmune causes. We report a case of a 59-year-old woman with a recent history of COVID-19 who presented with progressive confusion, incontinence, and abnormal behavior. She was ultimately diagnosed with anti-NMDA receptor encephalitis, a B-cell mediated autoimmune condition characterized by IgG antibodies targeting the NR1 subunit of the NMDA receptor. So for case summary, a 59-year-old female with hypothyroidism, hypertension, type 2 diabetes, fibromyalgia, and recent COVID-19 infection presented with subacute encephalopathy, confusion, and urinary and fecal incontinence. Initial evaluation in the emergency department, including imaging, laboratory studies, lumbar puncture, was unrevealing. She was referred to psychiatry for presumed mood disorder, but progressive neurological decline led to hospital admission. Repeat cerebrospinal fluid analysis showed elevated mononuclear cells without evidence of infection or malignancy. Brain MRI demonstrated no acute intracranial abnormalities, as you can see in figure 1. She received empiric treatment with antivirals, corticosteroids, and plasmapheresis without clinical improvement. A CSF autoimmune panel later returned positive for anti-NMDA receptor antibodies, establishing the diagnosis. She was treated with rituximab. Her hospital course was complicated by aspiration pneumonia, status epilepticus, MSSA, bacteremia, and suspected catatonia. She required intubation, antibiotic therapy, tracheostomy, and PEG tube placement. She was discharged to long-term acute care with plans for neuroimmunology follow-up. Discussion-wise, anti-NMDA receptor encephalitis is a rare but increasingly recognized cause of autoimmune encephalitis, with an estimated incidence of 1.5 per million people per year. It is mediated by IgG antibodies targeting the GLU-N1 subunit of the NMDA receptor and is classically associated with young females and ovarian teratomas, though it can occur across all age groups and in the absence of neoplasm. Clinical presentation typically involves a subacute onset of psychiatric symptoms, speech disturbance, seizures, movement disorders, and autonomic instability. Infectious triggers, most notably herpes simplex virus, are well documented. More recent studies suggest COVID-19 may act as a potential trigger through molecular mimicry mechanisms. Anti-NMDA receptor encephalitis should be considered in patients with rapidly evolving neuropsychiatric symptoms, particularly when initial infectious metabolic or psychiatric workups are unrevealing. Early diagnosis and treatment are associated with improved outcomes, though the ideal window for specifically immunosuppression has not been clearly established. Do you have any questions? Otherwise, I can present the key points as well. Anti-NMDA receptor encephalitis is a rare autoimmune encephalitis that may present with psychiatric symptoms, seizures, and altered mental status. Viral infections, including herpes simplex virus and COVID-19, are potential post-infection triggers. Diagnosis relies on cerebrospinal fluid testing for anti-NMDA receptor antibodies, and early recognition and immunotherapy are associated with improved cognitive outcomes and reduced disease severity.
Thank you so much. For this patient, was a trigger like infection, tumor, anything else? Do y'all know what caused her to develop this encephalitis?
So based off this case, it was presumed that COVID-19 may have been a possible trigger since she recovered from her infection a month prior. So I can talk about a possible pathophysiology that was presented in one of the and one of my research sources that I read was that through molecular mimicry mechanisms, COVID-19 may be a potential trigger, mainly through certain viral proteins such as NSP8, NSP9. And so through those viral proteins that can activate the T cell, B cell response, and then ultimately being able to disrupt the blood-brain barrier and causing these neuropsychiatric symptoms, that is NMDA receptor encephalitis.
All right. Thank you so much, Sindhoora.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.